Okay, we have Ruth Roberts, the Director of Community Mental Health Hygiene Services with us.
Okay, thank you, Mr. Chairman, and thank you, Board of Supervisors. 2016 proved yet to be another very busy year for mental hygiene services. We noted throughout all of our programs that we are seeing an increase in more complex, more challenging sort of disorders. No longer are we serving individuals with a singular diagnoses. We're now typically serving individuals with multiple diagnoses and also working very closely with their physical health providers in terms of looking at how best to deliver health care for this highly complex and demanding population. I also think this trend is occurring because and you may have noticed this when you stepped into your primary care provider recently. A lot of the low-level, what I call low-touch, low-intensity behavioral health services is now taking place in primary care settings. So they're doing a lot of screenings. They're asking people about their mental and emotional stability, hoping that they can take care of things at that low touch point. And so we're likely to continue to serve those more complex individuals in our outpatient clinic. I want to just touch down on a few areas. One, of course, is forensic services. Those are the services we deliver in the jail, but we also, on the outpatient basis, provide adult sex offender treatment and domestic violence treatment. We have seen an increase in the number of referrals for forensic services. Certainly the services we're delivering in the jail, there continues to be greater demand for those services. And one statistic that caught my attention this past year when I was reviewing the data is that we're now seeing a much younger individual that we're serving in our forensic program as well. AOT, assisted outpatient treatment, otherwise known as Kendra's Law, we've seen an uptick in that. And another factor I think that's contributing to these upticks is the fact that, as was mentioned earlier by Mr. Flanagan, we have seen this constriction of state-operated institutional care. We've moved away from caring for individuals with mental disabilities in institutions and in inpatient settings. And those individuals are now much more likely to be showing up not only in our clinic, but showing up certainly at Betty's front door, showing up unfortunately in the jail, coming to the attention of law enforcement. So we here at the local level are left with the challenge of how best to manage and meet the needs of that population. As you know, we expanded in 2016 our school-based behavioral health services. We're really focusing on measuring outcomes in three distinct areas. One is social and emotional development. The other is school performance, because kids who stay in school and stay on track for graduation tend to have better health outcomes in life. And also community outcomes. We're looking at a sense of community connectedness, a sense of responsibility, and also exhibiting what we call pro-social behaviors, or as my mother would say, you're behaving yourself. So that also crisis service, what's mentioned here earlier is the consolidation of services or the sharing of services. We have been sharing our crisis services with Delaware County, Schoharie, in Otsego County, and we contract with the neighborhood center which is based in Oneida County, and they provide after hours weekend crisis services for our clinic. And in 2016, the crisis services across those 4 counties served just a little shy of 5,000 individuals in 1 year. Switching quickly over to alcohol and drug services, again, we saw an increase in not only the number of individuals served, but the number of services actually delivered. And again, we saw that trend of seeing many more adolescents entering treatment. School-based Substance abuse prevention, we're in 4 school districts, Sherburne, Green, Afton, and Oxford. And those, we have 1 OASIS-funded prevention worker. She stays very busy. I'm working with OASIS now and also through the Chenango Substance Abuse Prevention Coalition to try to leverage some additional funding that would allow us to add another prevention worker. As far as OPWDD, they did close the Broome Developmental Site in March of 2016. They were right on time for that. And as was mentioned earlier, the goal in OPW is very close to achieving their goal of only having 150 individuals with intellectual and developmental disabilities in institutional settings. So 150 will be the total number, including New York City. And of course, we have Valley Ridge here in Chenango. They're licensed to have 60 beds, but when I checked with them last, they were running closer to 42. So I just want to also mention 3 things real quickly here, because I think it's good for you to be aware. We are, the three areas I want to touch down on is changes in healthcare delivery, our court and forensic activities, and just a few words about the school-based services. The transition to a managed care environment continued to accelerate through 2016. And we're really seeing this kind of take ground in the work primarily that we do through our outpatient clinic. And this is further complicated now with the policy changes at the national level in Washington and just not knowing what it's actually going to look like in terms of that healthcare bill. But I can guarantee that whatever changes occur at the federal level, they will have an impact, of course, at the state level and will ultimately require us to make some changes at the local level. And at the same time, there's the development of what they're calling value-based payments, which is scheduled to go into effect in 2020. This is a shift away from fee-for-service and a movement towards receiving payment based on achieving desirable health outcomes. And we're going to be sharing this in behavioral health. We're going to be sharing this with our physical health providers. The insurance industry refers to this as the triad or triple aim, which represents an enormous paradigm shift. So payment will be made based on 3 things: the customer's experience, improving those health outcomes, and reducing healthcare expenditures. So we're beginning now to prepare as a clinic to get ready for that value-based shift, and it will require us over the next few years to really change the way that we schedule appointments, the way we measure treatment progress, and the way that we deliver our treatment services. I think another thing is it's important to know in the discussions about value-based payments that for the first time social determinants are part of the conversation. Social determinants are recognized and included in these discussions, and in Chenango County, the social determinants that often create the greatest challenges to individuals in achieving positive health outcomes are lack of transportation, lack of access to safe and affordable housing, factors related to low socioeconomic status, which include those challenges that often exist in rural poverty. For the first time, the payers, so Medicaid, Medicare, and commercial insurance, providers of health care, that's providers such as us, the primary care providers, the specialists, and also the policymakers, are together exploring ways to address some of these social determinants that often get in the way, complicate, and make health care delivery very, very expensive. We spend the most in the world on health care, and we get the worst, some of the worst health outcomes, and we've got to figure out a way to turn that around. The second area I want to touch down on is court-related forensic activities. As we focus on the delivery of these highly medicalized services that we're providing in our outpatient clinic, we're having to be very careful in terms of corporate compliance regarding medical necessity and determining medical necessity. And in the past, it was a little fuzzy. If I was doing a mental health evaluation for the courts, or if I was doing a mental health evaluation because somebody came in and requested an evaluation, that I would still have a mechanism to bill for those services. Any activities that are requested by the courts are not considered to meet the criteria of medical necessity. And so I'm having to really look closely at the number of services our department is providing the courts in terms of these court-related activities. Some are things that the court or that the county is clearly on the hook for and is required by law to pay for. Those are things like the 730 evaluations that determine capacity. I stopped and I looked at that this past year, and I realized when I evened the population up I compared us to other counties across the state. And what really caught my attention was when I was comparing Chenango County to Broome County. All things equal in terms of population, we have over twice as many requests for those 730 evaluations. And so I started digging and sort of asking, why is that? What's driving that? And I'm hoping that over the course of this year and next, we can start to see that number come down. Other required evaluations or work that the county is on the hook for is when an individual is in our local county jail. Fortunately, we didn't have anyone in 2016 where this was the case, but we do in 2017. And here we are June, if we're only halfway through the year, and the county has already been charged close to $40,000 for one individual. But this is when an individual is in our county jail, requires hospitalization, psychiatric hospitalization, and must go to one of the, I think there's 2 or 3 forensic state-operated units at $808 a day, of which the county is on the hook for 50% of that. So again, I'm wanting to pull out some of these forensic court-related activities, wanting to really track how much this is actually costing us as a county, and I'll be keeping you posted. And then finally, school-based mental health services or behavioral health services. Last year, our school-based workers were called upon to respond to critical situations that threaten the life and safety of children and youth. Examples of this are responding to self-abusive behaviors, such as cutting, burning, suicide attempts, suicide ideation, thinking about suicide, eating disorders. And if you think that these things are probably only happening with older adolescents, you're wrong. These things are happening in elementary schools, in primary level schools. Challenges such as food insecurity. In a county where agriculture is so important, it's hard to believe that we have children that we're working with who can't know from day to day if they're going to have enough food. Unstable housing, addiction. Addiction is just such a damaging effect to a child and in a family. And while we have to address these high-risk, high-need situations, we're also very committed to prevention and looking at preventing small problems from becoming large, lifelong problems. The school-based workers are dealing with families, and they're aware of the stressors that families are facing every day. Engaging parents in positive ways to support them and include them in the course of treatment is absolutely essential. The more we direct our efforts towards strengthening the parent's ability to take care of the child, the better off the child will be in the long run. We know that. We're in and out of their life. That parent or those parents are there for the lifetime. We believe it's important to work with the entire family system. We see healthy families, healthy individuals, healthy communities going hand in hand. So in closing, Chenango County Community Mental Hygiene Services remains committed to offering the highest quality service to the mentally disabled in Chenango County. We strongly believe in promoting hope, wellness, and recovery, and we consider it an honor to serve the citizens of Chenango County. Thank you.
Thank you. In light of our shared services public hearing that's going to start here in 2 minutes, I would ask that any supervisor has questions for Ruth to contact her and do that. I'm sure she would be very willing to answer any questions.
Yes.